Namaskar. I am Dr. Asha Jain. I am a gynecologist and a fetal medicine specialist, preventive oncologist, also gynec sonologist. My fields of interest are saving the uterus, fetal medicine, obstetric gynec ultrasound, critical care, and preventive oncology and colposcopy. I have more than 32 years of experience. My hospital is a FOGSI recognized center for ultrasound training and colposcopy training. I have been certified from Fetal Medicine Foundation UK, and also I've taken a certification from Gynec Academy. So I will be speaking today on sonography in pregnancy, when and why. So this is a very basic question. And because we are today living in India, I will discuss a few practical points about it and also about how we are going to go about it, when and why. The flow of the presentation is going to be introduction, then the guidelines, the various guidelines that are there, the anomalies that can be ruled out, Doppler and growth, Government of India guidelines, and indication with the time of scan. So we now proceed to the introduction. There may be as many as 4,72,177. The range being 4,21,652 to 5,22,676. Congenital anomaly affected births in India each year. These are live births that are occurring. So about 5 lakh births are with anomalies. And these anomalies account for 8 to 15% of perinatal deaths and 13 to 16% of neonatal deaths. So many deaths are occurring, all because of congenital anomalies. And along with this, congenital anomalies account for 14% of abortions. WHO recommendations. What are the recommendations that WHO is saying? When we talk of WHO, I have just put this forward because WHO is looking at the whole world as an entity. And it says the guideline is what is the minimum that can be offered to everyone. In its 2016 antenatal care recommendations for pregnant women, it recommends one ultrasound before 24 weeks. This will estimate the gestational age, improve the detection of fetal anomalies and multiple pregnancies, reduce induction of labor for postpartum pregnancy, and improve a woman's pregnancy experience. WHO does not recommend a routine ultrasound after 24 weeks who already had an early scan. One potential benefit of an early scan performed correctly is the increased accuracy and precision of gestational age assessment. And this will help manage threatened preterm birth and postpartum pregnancies. Comprehensive health system support for a minimum standard of ultrasound services, appropriate referral, and management of complications identified by ultrasound are important components of implementing ultrasound recommendations. And then you also have to scale this up to a low resource setting. What they are planning is that every pregnant woman in the whole world should have an ultrasound before 20 weeks. Where did I get the data for anomalies? These are the two papers published in ijpcbs.com and also a research article that is by Prajakta Bhede and Anita Kar in BMC Pediatrics. It's an open access paper and you can have a look. Now we come to beyond fetal aneuploidy. Previously, as you see the WHO recommendation, what are they saying? They are saying do one scan at or before 24 weeks. That's it. Now we come to the Fetal Medicine Foundation, the International Society for Ultrasound in Obstetrics and Gynae, the Barcelona group. Everyone now has come to this, beyond fetal aneuploidy. What is it? It is this. It is an inverted pyramid of antenatal care. What it is trying to tell you is that instead of having more attention in the later part of pregnancy, you will give more attention in the earlier part of pregnancy. And what does it mean? Gestational age and multiple gestation, aneuploidy and anatomy, early adverse outcomes can all be seen at the 11 to 14 weeks ultrasound. You can also see anatomy, please remember. In the 18 to 20 week ultrasound, you have anatomy and you also have preterm birth. And then you have 34 to 36 week scan, which will tell you about late IUGR, anemia, late onset anomalies, and the rest. But the focus is in the 11 to 14 week ultrasound, because this is the Fetal Medicine Foundation, which gives you a license for nuchal translucency, nasal bone, tricuspid, ductus venosus, and this is what will tell you that the patient, it gives you a license, and according to that license, you can go ahead and examine your baby, and the efficacy of that combined with a prenatal screen is more than 90% in detecting aneuploidies. That means the Down syndrome and other triploidies along with X and Y abnormalities. And also it rules out a lot of other anatomical defects. Now we come to the 11 to 14 week scan as per the ISWOG guidelines. This is updated in 2016. And what does it tell you? Have a look at this. These are the measurements that you have to make. This is, this tells you that these are the measurements that you have to take. The baby has to be in this correct position. It has to be a mid-sagittal view, and the neck should not be flexed. It should be in a neutral position, and you measure this baby from head to the rump. Crown rump length is what you're taking. Along with this, you're going to measure the femur bone. You're going to see the angle of the thigh with the leg and with the foot. This image, if it is like this, tells you that everything is fine. Then when you take the NT, you see the nasal bone, you see the nuchal translucency, you see the IT, you see the midbrain, and you see the palate, and it rules out a lot of things. It rules out palatal defect, it rules out anomalies, it rules out aneuploidies. A thick nuchal translucency is associated with a lot of problems. It is associated with anomalies of the heart, anomalies of the brain, anomalies of the circulation. So we have to see the NT in the correct position. Then you have to measure the biparietal diameter. You also have to see the head circumference, the abdominal circumference, and you have to take certain Dopplers. Now, what are those Dopplers? You have to take the uterine artery, the umbilical artery, the ductus venosus, the tricuspid. There should be no regurgitation in the tricuspid. The A wave should not be reversed in the ductus venosus. So these are the factors that you take in. And do you stop here? That is the question. These are the standard images. And when you're storing your images in the first trimester scan, have a look. You need to store the crown rump length, the insertion of the umbilical cord. Then you have to see if in case of twins, whether it is a peak sign or a T sign. Then you have the brain showing both choroid plexuses, the thalamus, the cerebellum, then the NT, both eyes and orbits. This is the coronal view of the face. Then you have to see the retronasal triangle. the heart with both lungs, where the heart should occupy 1/3. And this is the 4-chamber view, the 4-chamber view in color, and the 3-vessel view in color. This is the minimum that you have to take. Along with this, you're going to take the stomach. Then you have to take the cord insertion, the bladder with 2 vessels on both sides. That tells you that the umbilical cord has 3 vessels. Again, both lower limbs, the tapering of the spine. This is both kidneys, both lower limbs, the complete integrity of the skin over the spine, and both upper limbs as well. So all this can be seen in the first trimester. That means 11 weeks to 13 weeks, 6 days, when the fetus is between 45 to 84 millimeter in size. Ideally, it should be above 60 so that you can see all this well. And once you're able to see all this, you will rule out more than 50 types of anomalies. Along with this, you also have to do the placental growth factor, the PAPE and beta HCG, combined with a good level 1 anatomical scan of the fetus. This will give information about possible aneuploidies, about the chances of preterm labor, intrauterine growth retardation, and PIH. It will tell you also that this woman might go into PIH, and we know that the incidence of PIH is really very, very high. It's more than 10%. And we can detect it, that this patient is going to go into PIH, and you can give ecosprin 150 milligram and prevent injury to the fetus. In more than 70% cases, you will be able to prevent PIH. So this is the first trimester detection of structural anomalies. It is published in the White Journal. And what is the conclusion? That about half of the major structural anomalies can be diagnosed in the first trimester. Increased nuchal translucency, abnormal ductus venosus appears to be associated with cardiac and skeletal defects, and this may facilitate early detection. So that is just that paper. But you can also detect PIH. Now, Fetal Medicine Foundation has brought it up in a huge way that you should always diagnose that this patient may get PIH and treat with ecosprin. And that way you can really make a difference to the life of the woman. Then we have guidelines for the mid-trimester scan. And see, if you see this chart, all the students who are looking at this webinar, I would request you to take a photograph. And these are the sweep 1 and sweep 2 that are taken, and along with the different sections of the baby that are taken in the second trimester scan. And these are the 50 different diseases that you can rule out, abnormalities that you can rule out. And how are they to be taken? Spine 1, sagittal complete spine, then coronal complete spine, then coronal section of the body. For the head, transventricular, transthalamic, and transcerebellar plane. For the thorax, lung, LVOT, RVOT, and crossover of LVOT, and 3-vessel trachea view. Abdomen, you have the transverse section of the abdomen with stomach and umbilical vein. Kidney should not be seen. Transverse section of abdomen at cord insertion. And then one that includes kidney and pelvis. Pelvis, transverse section of the pelvis, bladder, both umbilical arteries. Limbs, you have to measure the femur. You should see 3 bones of both legs, both feet, and normal relation to legs. 3 bones of both arms, both hands, and normal relation to both arms. For the face, you need to see the coronal view of upper lip, nose and nostrils, both orbits, both lenses, and median facial profile. So, this is the second trimester scan, and these are the images. The standard fetal biometry, the biparietal diameter at this section, that is the transthalamic section with the head circumference, the abdominal, where you see the curved C of the hepatic vein, and the stomach. Then you have the femur, which is correctly measured. You have the face, the nose, the lips, the chin. Then you have the nasal profile where you can see the nasal bone. You have both eyes with the lenses and the distance in between both lenses. You also have the brain, 3 sections in the brain. Then you have both kidneys, spine, umbilical vein, and this is the stomach, abdominal circumference. When you go to the heart, you have the 4-chamber view. Then you have the left ventricular outflow tract, the right ventricular outflow tract. Then you have the 3-vessel view, and then you have the 3-vessel, and this is the trachea. These 5 views have to be taken in the heart. This is the position of both hands and limbs when you are taking both upper limb and lower limb, and we need to measure both right and left of both hands. So that completes the 2nd trimester scan. Then you come to the 3rd, and that, as per WHO, FMF, Barcelona, SFM, ISWOG, everybody says you cannot miss the 2nd trimester scan. Then you come to the heart. Now, these are the 5 sections of the heart, and I've already shown you the images. The 4-chamber view, then the LVOT, the RVOT, the 3-vessel view, and the 3-vessel trachea view. Use of Doppler. Now the Doppler is done on the umbilical artery. You have to do it on the middle cerebral artery. You do it on both, not just one. Then you do the uterine artery, both, and you take the ductus venosus, which has to be very correctly measured. And once you have done with this, including the biometry together, is what you're going to measure in the case of fetal growth retardation or any compromise to the fetus. So all of these are relatively connected, and you will be able to find out whether the baby is going for growth retardation if they are falling off the charts. Now we come to the guidelines of India, Ministry of Health and Family Welfare notification, the PCPNDT Act, which was modified in 2014. They have given certain indications, and I have added them. This is there in your ultrasound F form. So in the early pregnancy or 7 to 8 weeks, that is the answer of when, and this is the answer of why. So you do it to diagnose intrauterine pregnancy or ectopic pregnancy. You also confirm viability. You confirm the age. So you date the pregnancy. You see the number of fetuses and their chorionicity. If there is an IUCD in situ, or there is contraceptive failure or MTP failure, that also can be seen. If there is bleeding or leaking, you have to see whether the baby is fine. And if the patient already has had an abortion, you would do an ultrasound to see that it is complete or not, or there are retained products. So this is usually done early pregnancy, 7 to 8 weeks. Now, what can be done anytime? That is, if the patient has bleeding or pain. So you want to assess the cervical canal and diameter of the internal os. If there is a discrepancy between the uterine size and period of amenorrhea, you don't know what is the exact size of a pregnancy. And if there is any suspected adnexal or uterine pathology or abnormality, in that case, any time in pregnancy, the scan can be done. 11 to 13 weeks, 6 days, and 20 weeks is when we are going to do detection of chromosomal abnormalities, fetal structural defects, and other abnormalities, and their follow-up. Supposing you've seen something at 11 weeks or 12 weeks, you confirm it after that again before you are going to advise the patient an abortion. Or if you want to have amniocentesis or any other procedure, so you need to repeat the test before you do it. 26 weeks to term is when we are going to see the presentation, position, assessment of the Leica amni. We are also going to assess fetal growth. 26 weeks to term, again, you will have preterm labor. If there are signs of preterm labor, if there is premature rupture of membranes, if you want to evaluate the placenta, what is the position, what is the thickness, what is the grading, and if there are any abnormalities, placenta is previa, there is retroplacental hemorrhage, or it is an accreta spectrum, all that can be seen from 26 weeks to term. Placenta previa is finally evaluated at 32 weeks. Then again, the umbilical cord, whether it is a 2-vessel cord or a 3-vessel cord, can be seen in the first trimester scan. But if the patient comes to you anytime later and has not presented earlier, this can be seen at any time. At term, you will see what is the presentation, if the insertion is velamentous or normal, if there is nuchal encirclement, what are the number of vessels, and if there is a true knot. That can be seen in the 3rd trimester. But whether it has a 2-vessel or 3-vessel has to be seen early on in pregnancy. 20 weeks to term, you would see the placental position, thickness, grading abnormalities. You would also evaluate the umbilical cord. In the 3rd trimester, you have to evaluate the previous cesarean section scar as well. You see the fetal growth parameters, fetal weight, fetal well-being. You also do color flow mapping and Doppler studies, which are mandatory to get a difference between small for date and growth retarded fetus. Again, from 10 weeks to 36 weeks, depending on the indication, you could do ultrasound guided procedures for medical termination of pregnancy, or you would do an ultrasound if you want to do a version and their follow-up. Also, if you want to do invasive interventions such as a chorionic villus sampling, amniocentesis, fetal blood sampling, fetal skin biopsy, amnio infusion, intrauterine infusion, placement of any stunt, then you have during labor. During labor, you can do an ultrasound to see whether the head has descended, what is the position relative to the ischial spine, relative to the pubic symphysis, and all through pregnancy. You can do it for medical surgical conditions complicating pregnancy, or for a research or scientific studies in recognized institutions. This is as per PCPNDT Act of India. So what is the take-home message? The take-home message is that sonography has different indications throughout pregnancy. As the minimum to rule out abnormalities and for maternal and fetal well-being, the minimum is what I'm saying. You need a scan between 11 to 13 weeks, 6 days, at 20 weeks, and at 36 weeks. But if you think of the absolute minimum as per guidelines, the mid-trimester scan between 18 to 24 weeks, ideally around 20 weeks, is a must. That every single woman in pregnancy should have a mid-trimester scan. Thank you. Thanks a lot for a patient listening. And if there are any questions, I would be glad to answer them.